Let's get started.
Sure.
Good morning, good afternoon, good evening, everyone. My name is Tao Hong. I'm a director of IIF. I'm also the program chair of ISF 2020. First of all, thank you all for coming to this session. In this session, we're going to talk about COVID-19. Just the same as most, if not all of you, I've been in quarantine for more than half a year. People around us were asking us, when this will end. What's going on? This is a pandemic. We have to work together to address the issues. So, we are honored to invite 5 elite panelists to this panel. The panel will be chaired by Nicholas Reich. We have, all the panelists from all over the world working with the frontline doctors, with the government, policymakers. So we want to, we want them hopefully give us some idea about what's going on, share with their work and give us some insight about COVID-19. So without further ado, I want to give the floor to the chair of this panel, Nicholas Reich.
Great. Thanks so much, Tao, for organizing this and to all the organizers of the conference. This is obviously an important and timely topic for a panel, and we're happy to be here. So I just want to say a couple words about the panel itself. So there are 5 of us. I'm going to be hopefully very lightly moderating what I think will be an interesting discussion with people from around the world bringing different perspectives to this. How we're going to start is we're each just going to take a few minutes to introduce ourselves. This part, I think, basically will happen without an interruption. Each of us will just take just a very few minutes. I think a few of us may have a few things to present. And then we have a few prompts that we're happy to start a discussion off on our own, but we're also really hoping that folks chime in on the Q&A and or the chat box just with questions, and we will sort of try to pick those off as best we can with the time that we have. So I'll just give a brief introduction of myself, and then we'll go through the panel. So my name is Nick Reich. I'm trying to share my screen here. Can you all see this okay? Yeah.
Yes.
Great. So I'm an associate professor of biostatistics at the University of Massachusetts Amherst in the US. My group has worked really closely with the US Centers for Disease Control and Prevention, the CDC, over the last 4 years or so, trying to build infectious disease forecasting models. We've focused over the last years on influenza, but when the pandemic struck in early this year, we have pivoted our efforts and have been doing a lot of work with CDC forecasting COVID. So we've been focusing on building short-term forecasting models. And it's not just that my team is building these models, we've created this COVID-19 forecast hub that serves as sort of a centralized aggregation point for teams that are around the world that are making forecasts of COVID-19 in the US. There are other efforts that have spawned off of this for other areas in Europe and so on. So I'll just this is sort of the main website. Please spend some time browsing around if you have interest. If you go, you can look. There's a lot of information on the About tab about our team, about talks we've given, a little bit about some of the research we've done. Just 2 other things I want to point out is that the data that we collect at the COVID-19 Forecast Hub, we essentially solicit forecasts from teams. We have over 50 teams submitting forecasts every week. And these data are then put directly on the CDC website. We're sort of the conduit for this data. And then we also create a single ensemble forecast that goes out for 4 weeks into the future, predicting incident deaths, cumulative deaths, hospitalizations, and incident cases at the state and national level, and also case forecasts at the county level as well. Some of this is also available on our sort of interactive visualization, which is linked to from the main page, but yeah, you can sort of go back and see what ensemble cast was saying at each week in the past. You can sort of navigate around and see see for each state also. So I encourage you to spend some time sort of browsing the site, because there's a lot of good information there and some nice visualizations. So that's all. That's sort of the COVID part of our work. You'll hear a little bit more from Ryan, who works with Carnegie Mellon, and his group has also worked with CDC. But without further ado, I'm going to turn over to another panelist to introduce themselves. Jurgen, would you go next? Don't forget to take yourself off mute.
Thank you very much. Thank you very much for inviting me. I very much look forward to sharing and learning. So just to give a very brief overview of what we've been doing. This is joint work with Jenny Castle and David Henry, and we started, surprisingly, forecasting the coronavirus pandemic as well. We started quite early on, and just have a quick look to where we were. We started about mid-March, when in the EU the number of cases had already gone up quite substantially, but the US was still very early on. Well, that seems an eternity ago now, March. And if we compress the time scale and look where we are now, then of course we all know the US is effectively in its third wave, may well be heading to 10 million cases. The EU is now rapidly going up, and there are lots of things going on. Now, there's many issues that we have encountered while trying to forecast. There are many data issues. There are errors in the data. The UK has some howlers. We can talk about that later. Would be funny if it wouldn't be serious. There are changes of definitions, like how do you count, what is a death, etc. Obviously, testing has ramped up very much, but this is in a sense an endogenous response to what is going on in the epidemic. There are technological changes. The one we probably look forward most is the development of vaccines. Unfortunately, data collection and reporting has sometimes become politicized. It's probably also a bit in the US. And there is seasonality in the data, not at first when we started, but later on that became quite clear. So all this introduces breaks on stationarity. Well, we'd like to have good data, but it's not under control. So we work with what we have. But all these changes impact modeling, the breaks, the changing seasonality, also the exponential growth that comes in multiple waves. And we shouldn't forget that what really seems to have quite a big impact as well, above the kind of standard issues, is that politics and policy makes a huge difference. For example, the US had a second wave in the summer, not the EU. Why was that the case? Is that a purely political thing? Is there something else going on? And I, for one, look forward to stopping forecasting and start looking back to the past and hoping that this is all behind us, of course. But our approach to this is really a purely statistical approach. We try to capture trend, we worry about these breaks, and more recently about seasonality, but we don't learn about the causes of the evolution. And just to end with the graph of Brazil, because I think we probably all would like to be in Brazil at this point in time. Unfortunately, that's not possible, but here you see our forecast and the outcomes on a logarithmic scale. We have been really looking at very short forecasts, so not 4 weeks, really just only 1 week. And again, Brazil, we started in mid-March when the number of cases was really low. Forecasting was very difficult, but after a while it starts to improve and it starts to track the outcomes much more clearly. Now, if you're interested in what we do, and I don't think we do really want to talk about that here, but we have 2 papers that's just appeared, one in the IGF and one in the Journal of Clinical Immunology and Immunotherapy. Thank you. I'll pass on to the next person.
Thanks so much. Sasha, would you go next?
Yes, thanks very much for organizing the panel and for having me. My name is Aravkin. I'm the Director of Math Sciences at the Institute for Health Metrics and Evaluation. I'm also Associate Professor of Applied Math at the University of Washington. So I have a few slides as well, talking a little bit about the IHME model. Can you all, let's see, slideshow. Can you all see this?
We see the presenter view.
Presenter.
We see.
Let's try this. Yes.
Yeah, that looks good. Yep.
Okay. So I wanted to talk a little bit about it. In the context, I have one technical slide, but I can go through that fairly quickly. Just wanted to give you guys a flavor of that part of the work. So as my team and I are part of the IHME COVID-19 forecasting team, which is a major effort started also at the start of the pandemic to forecast cases and deaths and hospital resource use. So the background of the project is the initial goal is to provide estimates of COVID-19 patient hospitalization to help UW Medicine plan for the first wave of the pandemic and understand what peak use might be had in terms of emergency room use and ventilator use. And then there was a lot of demand from multiple hospital systems that prompted the model to expand to all US states. And the release of state forecasts led for a lot of demands for local and national estimates. So essentially now IHME computes forecasts for subnational locations all around the world and then aggregates them up to national and global levels. And the model has been extended to understand sort of the continued COVID-19 infections and resurgence as we've been going through the pandemic, and then also the role of some of the underlying drivers, including mobility testing, mask use, and mandates. This is a large collaboration led by Chris Murray and other faculty at IHME. So just a little bit about the model. The model is an SAR statistical model or data-driven SAR model, which is informed mainly by death time series in each location, though there's other leading factors that are used as well, like hospitalization and testing. There's a regression that's done to link infectivity to some key covariates. I'll actually say a couple of words in the technical slide next about this. And then we can use this to forecast deaths, infections, and hospital resource use moving forward. And then there's a tool that you can also visit. I'll paste the link following Nick's example, where you can look at the global, national, or subnational levels. And then you can look at deaths, daily deaths, infections, and testing, hospital resource use, and some of the drivers. So in terms of the technical component, the model is quite interesting. It tries to capture both transmission dynamics and also relate those dynamics to some key drivers. So the slide is a little bit busy. I think we have all seen SCIR and other variants of these models used in transmission dynamics. So one thing that this model tries to do is it tries to capture in each location, tries to estimate efficiently first an infectivity time series, which is often called beta T. So once we capture the infectivity time series by location, we can then take that infectivity time series and then regress it against key drivers, which in the current model are pneumonia seasonality, testing per capita, social distancing mandates, mobility, and mask use. And then if you have that regression, then you can forecast the drivers, which themselves, forecasting each one is a difficult problem, but forecasting each driver is more reasonable than forecasting the entire thing as a whole. Once you forecast the drivers, you can forecast forward what the infectivity is doing. And if you forecast what the infectivity is doing, you can run the ODE model forward, and that creates for you a forecast of what will happen to each compartment. Then you can get information that you want from the compartments. Then you can aggregate uncertainty across draws. Just to finish off with some impact, the model has been cited a lot in US news. One thing that meant a lot to me personally is the model was cited by the current administration as a reason not to push reopening US in April. And then the Biden campaign has credited forecasts with the IHME forecast for Biden's stance on masks. And then just to preempt some of the prompts that we might have, there's been IHME has been doing a lot of ongoing engagement with policymakers around the world and trying to make the scenarios and length of forecasts to be as useful for planning purposes as possible. And then there's a paper that just came out a few days ago in Nature Medicine called Modeling COVID-19 Scenarios that summarizes these results. And then the news are pretty bad for the winter, so that as many as 511,000 people under the current status quo may die by the end of February 2021 in the United States. But that there's some things by looking at the drivers that we can do through national policy. So if we drive up the mask use high enough, we can prevent a lot of these deaths. So let me just end there. Thank you.
Thanks, Sasha. I see there have been some people chiming in with links in the chat, and I think, Sasha, you have a question in the Q&A. So maybe if the people are directing questions to us, make sure that you say who you're directing it to. I mean, I think this is obviously for you, Sasha, but please, we should just try to pick them off as we go. Ryan.
All right, can you guys hear me? Can you guys hear me okay?
Yes, very well. Yes.
Yep.
All right. Thanks, Nick, and thanks for inviting me, Tao, and it's nice to, as Jurgen said, get to learn from everybody else on the panel. So I'm going to also share my screen quickly. All right. My name is Ryan Tibshirani. I'm a faculty at Carnegie Mellon University. I'm jointly appointed in statistics and in machine learning. And I'm one of the two leads of Carnegie Mellon's Delphi group. And like Nick's group, we're one of the CDC's 2 centers of excellence for flu forecasting. So I've actually been working on epidemic tracking and forecasting since 2012, primarily on flu, seasonal flu in the US. And like Nick's group, we turned in the early months of this year to focus on COVID. And I just threw a couple links on my first slide here, but I'll type them into the chat so that you guys don't have to worry about them now. So I just wanted to give a very high overview of what our group is doing, and I hope this provides a nice complement to some of the perspectives offered by the panelists, because a lot of what we're doing is actually not forecasting, but to support forecasting. And I guess you could say that Nick's group is in a similar position in supporting forecasting from a different perspective. So lots of nice complementary points to discuss. So a lot of what we've been doing since I would say February of this year has been actually to work at what I would call the data floor, to try to create COVID indicators that give you different pictures of what the pandemic activity looks like in the US, apart from let's say typical public health reporting measures like confirmed cases, hospitalizations, and deaths. And so I can speak very briefly about what some of these indicators are and where they're coming from, but they're powered by relationships we have with various companies in tech and healthcare. So we're very lucky and very fortunate for that. In a time like the current pandemic, there's a lot of very generous entities being willing to do things that they would not usually do, let's say in order to make important data publicly available. So that's really been the bulk of our effort, has been to try to make these indicators public through an API that we put out, which is called the COVIDcast API. And then there's some stuff that we do on top of that, like we also work on forecasting, and we have some kind of tools for forecast development and forecast evaluation that I'd be happy to talk about if that ever comes up in a prompt. But let me just flash up one slide which shows the data sources and where they fall with respect to what some people call the severity pyramid, and then I'll quit and offer the floor to the next panelist. So this is maybe a more detailed severity pyramid than what gets typically shown in classical epidemiology, where each rung refers to a different, let's say, way in which the pandemic is affecting a society or an epidemic in general, all the way from deaths down to general population behavior. And you can imagine that the reason why it's useful to lay it out this way is that there's typically a hierarchical nature between these rungs, so that if I wanted to understand deaths, for example, through forecasting as one problem I cared about, it'd be helpful to understand ICU admissions and hospitalizations. And if I wanted to understand, let's say, ascertained cases as reported through, let's say, COVID tests, then it would be helpful to understand, for example, doctor's visits that might occur before a person gets a test and gets confirmed with COVID, and population behavior, for example, things like mask use and mobility. So I've written here, maybe it's kind of small, I'm not sure if you guys can see it. I've written here a bunch of different data sources that are available that give you a picture of what's happening in each rung. And then in two colors, blue is things that are currently publicly available, as made available by groups like JHU and the CSSC group and USA Facts, for example. They've done a heroic job of assimilating public health reports into one convenient basically location for the world to use. And then the rest that are colored in red are data sources that our group has worked to make available that wouldn't be available elsewhere. So I'll just really quickly point out two categories. The first category is based on medical claims. So we've access to a huge fraction of medical claims at this point that we aggregate and make publicly available. We aggregate them according to, let's say, buckets of ICD codes. So we can produce alternative measures for hospitalizations due to COVID than what would be reported through, let's say, a state or county dashboard. And we also are able to produce indicators that point at outpatient visits that are COVID related, which is currently not available anywhere else as far as I know. So people that are visiting the doctor in real time, all of these are at the county level, by the way. In real time at the county level, people visiting the doctor's office with COVID, for COVID-like reasons, according to the ICD code that gets filled out. And the other kind of category, apart from medical claims, is based on a massive survey we're running with assistance or with partnership through Facebook. So this survey reaches about 100,000 people per day on average, or in fact, it's taken by about 100,000 people per day on average, so it reaches many more. And through it, we're able to ask about symptoms, but also a bunch of different behavioral type components like mask use, whether they're actively practicing distancing, whether they're still working, if they're working, what kind of occupation that they're in, et cetera. And again, this is at the county level available in real time, so we can produce indicators, for example, on current mask usage, or on who's experiencing COVID symptoms, self-reported. So yeah, let me quit there. I'm happy to discuss more details, but that is the kind of gist of our effort.
Thanks so much, Ryan. Pete, are you ready to go next? Wrap up our introductions?
Okay.
You can see that good.
Okay, my name is Piet van Mieghem, Delft University of Technology in the Netherlands, Europe. I should say I'm not a forecaster, but I will tell you something about a network science point of view. And just probably a couple of very simple slides. A network consists of two identities, basically, a process and a graph. The process is easy, actually, if we talk about epidemics. It's a transport of the virus from A, and A can be a person or can be a group of persons from A to B. And it goes over a structure which we call a graph. And most of the people know a graph, so a link in the graph means that there is a relation between two nodes in the graph. The focal point, basically, of network science is the theory of processes on a graph, and a cornerstone is the duality between process and graph. I come immediately to that. So in epidemics, on brief, what is known? Well, we have good models about close populations with N individuals, accurate models on any fixed graph. So these are mean field approximation types in a Markovian setting. What is still open are models on networks that are non-Markovian. And more important, actually, I said already that the duality in a network is you have the process, which almost everybody focuses on one process, and that's the transmission of the virus. However, we have actually two processes. Namely, we have a human mobility process, which actually generates contact processes. And that's what I call a time variant network. And then there are two flavors, actually, that these two processes, either the epidemic process, the COVID process, the transmission of the COVID process on the one hand, and the other hand, the human mobility process, they are independent, then it's reasonably easy. And the adaptive networks is that there is a coupling between them. And the coupling exists in the fact that there might be that you refuse a contact with somebody if you see that they are infected. So that's a typical example of an adaptive networks. So on the open population, in contrast to classical epidemics, there are hardly any network science papers. Probably the network viewpoint for open populations is not a very good one. And the major reason is that a graph is represented by a matrix, an adjacency matrix, and that has, well, that's a fixed structure. If you go to a higher dimension, more nodes, you're in another space. Okay, roughly, then epidemics, it was already said, there are two types of epidemic compartments. You have the single disease realizations, and that's what we all use. That's the SIR type model, which is the simplest one. And there you see basically a transition like a network, which is a tree. It's just a line. You go from the susceptible to the infection and then to the removed. And then you have a second type of compartment models, and that's our diseases with reinfections. And reinfections means that from a network point of view, you have loops. You don't have a graph anymore, right? And so you have here two compartments, SIS, which is the simplest. What we now do is, I give you a flavor. The simplest one is an SIS mean field equation. I just explained, and I give only one equation to just let you know what was actually our role by studying basically predictions. First of all, in a discrete time, it means that each time slot you have information, data, and then you can write the difference equation. And the difference equation is actually in the discrete time. You see here that k plus 1 is a function of k, so on the right-hand side. And you have two basic actions. You have a curing, so it means your probability of infection. If you are not cured, then, well, you're staying infected. And then there is a second thing, that is the infection term. If you are not infected, you can get infected by all your neighbors in the graph that are infected, right? And so you see here the matrix element of the infections of your neighbors, and here you see the curing. Now, why do I show this? Because if you look to that equation, right, you see that from the point of view of the probability of infection, the equation is nonlinear. Why? You have here a linear term, but here you have a product of two the same terms, so it's nonlinear. However, from the point of view of the vector, the curing vector or the matrix, it is completely linear. And a linear problem, we can solve this. So what we came actually to prediction by considering an inverse problem. So you have an epidemic process on a contact graph, you assume whatever model you have with compartments, and then you are normally possible to generate a dynamic process as a function of discrete times or continuous times, but I choose here discrete times. So you have here the viral state sequence of any node in the graph at discrete time 1, 2, 3, and so forth. So I just said before that if this is given and you want to go back to your model, you have a linear process. And you know, we can do linear processes. We are very good in the linear processes. However, when we came to data, we filled it in, we saw that it was a linear process, but it's seriously underdetermined. However, we have problems. We can actually translate the linear problem to a kind of an optimization problem. And the outcome is that we can actually make excellent predictions of the process, but we can hardly say anything on the graph. And that's actually a fine, interesting contradiction. So here you see the prediction of the process. What we do is we learn a bit until an observation point. We learn here the parameters, and once we have the parameters of the model, we can predict here the process. And you see that the predictions, which are here in red, are quite well because they are following the precise blue curves. On the other hand, the reconstruction, the model actually to generate this assumes an underlying network, but if we plot the characteristics of the underlying network, what we have actually here, this is our underlying, and that's the real underlying network. Here you see the degree distribution, then it's way off. Actually, it's a very simple thing. we cannot construct the graph. But on the positive side, we can do accurate prediction of the network dynamic without knowing the network's topology. And the reason why we don't and we cannot know actually the network is that one virus outbreak is insufficiently to agitate the network dynamic modes. I'm not going to get more details, but what we actually can do is, and that's our COVID action. You see here again the data up to a certain point in blue. So, and we can predict the short time predictions for any node in our network. Only the short time. So, and we do this with our, we call it NIPA. This is our network inference-based prediction algorithm. So in conclusion, given the infection data in space, well, in a network and in time, we can do accurate short time prediction. However, we cannot predict long time prediction. And I think that's a hard problem. And then actually for this discussion as a panel and observations, a general thing what I'm seeing is we have just insufficiently, well, we have insufficient measurements. In Dutch, we say meten is weten, meaning that the more you measure, the more you know. And here, that's my impression, we don't have enough good measurements. Okay, then another thing, what I am frustrated about is, we don't use any good digital technologies. So, for instance, apps on a smartphone, base stations, sensor data, they are insufficiently exploited, and the reason in Europe is for privacy, you can't use them. But actually, we think there are methods, if we can use them, you can also predict or you can determine nearly everybody in a network. Yeah, if you use mobile apps, everybody in a network that is infected. So to some extent, you can achieve more or less the same thing without a vaccination development. It is less complex. What I also see is that there is no optimized COVID-19 strategy because each country claims to have the best method and they're all different. And then a more political choice lies, in my opinion, in the triangle, yeah, choosing between freedom, health, or economy. So that's more or less what I wanted to say as an introduction.
Great, thank you, Pete. So let's see. I think that there have been questions coming in both on the chat and in the Q&A. Some people we have been trying to answer the ones in the Q&A. So please, if for attendees, please keep the questions coming. I see there was a hand up in the attendees, but I think maybe that question was answered. So maybe I'll launch with one of the questions that I would be interested to have us each ask. We've sort of each given our sort of narrative description of what our project is and what we're doing. I wonder if we could go around and in very rapid fire talk about what outcomes our team has been looking at actually forecasting in the short term. Maybe just pick one or two if you're forecasting a lot, Sasha. and I'm curious to hear about see if we can come to a consensus on predictability and what we've learned about how far into the future we can actually forecast some of these outcomes that we're looking at. So again, just really brief, some of the, you can even pick one if you have a lot, an outcome that you're forecasting, the horizon that you're forecasting it at, and what you feel like you've learned about how far into the future those forecasts are accurate.
Well, shall I start then?
Go ahead, Jurgen.
Yeah. Yes, so we do very short term, 7 days. We were very conservative, and I think we probably could have done a bit longer than that. For many regions, about 500, including local authority regions in England. But my feeling is that it makes a lot of difference where in the pandemic evolution you are with forecasting. At the very early stage, when you're exponential growth, I think lots of models really struggle because there's no anchor. And then once we're beyond that and things settle down, the forecasts do get a lot better again. But then we have another wave coming up, so it gets worse. And my feeling is that perhaps the longer term forecasts are not as good as we'd like to think.
And Jurgen, what's the outcome exactly that you're forecasting?
We're looking at confirmed cases and deaths.
So you're looking at confirmed cases and deaths. 7
Yes.
days ahead at sort of
7 days
fairly small spatial regions in the UK.
No, all over the world.
All over the world, okay.
About the 50 states of the US, about 50 countries, and about 300 areas
Okay.
in England, not the UK.
Okay.
I'll
Anybody
go
else?
next. I guess
Yeah, go
people
ahead,
are people are not jumping in. So my group is similar to Nick's group in that we are both working on a problem that's structured, a problem that's been structured in a common way across many of the groups working with the CDC. So we're working on forecasts 1 to 4 weeks ahead of incident deaths and incident cases. And for us, we're looking at incident deaths at the state level and incident cases at the county level. And I'll just throw in a couple of discussion points that I'd be curious what other people on the panel think about. 2 things here. One is very few groups, at least in the groups that work with the CDC, actually submit forecasts for all 3,200 counties in the US. I think that's correct, Nick, right? Most groups pick only a couple hundred. And I think that's not a problem necessarily of computational tractability. In my opinion, it's more about the fact that, I think Jurgen actually said this already, these counties are in very different situations with respect to their own pandemic story, so to speak. And so let's say, if thousands of counties have only experienced a small cumulative number of COVID cases, it's very, very different than looking at, let's say, counties that make up New York City. And so it's almost like you're asking for 2 different things. You're asking to forecast the pandemic in New York City, but then you're asking to do something that's more akin to hotspot prediction in the rest of the US. Like these counties that have seen almost no COVID activity, what are they going to see? So I think of it as 2 different problems. And so we tend to just break it up into the counties that are more active because that's tractable. So I'm curious what the other panelists think about that. And the second discussion point I'll just lob out there is that, and I'm not sure whether, for example, folks who are making long-term predictions think the same way. I think of long-term predictions as being more about counterfactuals than about accuracy, in the sense that I don't think when groups are making forecasts that are meant to be 6 months out, that really we would put a lot of faith in accuracy in those models, or in whether those models are even well calibrated. But it's more about answering a counterfactual question, which is, if the following measures were implemented, this is our best guess of what would happen, accounting for all the confounders in some way. And so I don't think of it even as really, you can't make a comparison between short-term forecasts and long-term forecasts. Certainly not the long-term forecasts that are counterfactual, because they're serving very different purposes.
Can I add something to that? Sorry, I'll wait. You go.
So I was going to say that we forecast deaths, daily deaths as one of the outcomes, and then out to 4 months into the future, which is a long time frame. But people find it helpful, I guess, going off of what Ryan just said, to think about, to understand the trajectory far out as well as close by when they're making decisions. So it's useful to have a long-range forecast for counterfactuals, and so people can think about what direction the pandemic may go and what help kind of underscore decision points now that might have an effect on it later on. There's some comparisons that were done with standard forecasting metrics at 10 weeks for forecasts available in June, but I think it would be useful to have a much more extensive study in general of forecasting measures, and then when forecasts change, when the estimates are different, whether we can pinpoint the assumptions that had the biggest impact. So I think I agree that that longer term forecasts serve a different purpose. I think it's always good to think about what questions each model is trying to answer when you're judging whether it is succeeding in answering that question, but I also think it's worthwhile to try to make the further out forecast as accurate as possible and then gauge their performance that way.
Sorry. I want to just add on to that. So we've been starting to, and I think you can expect over the next few weeks and months to see more work coming out from the COVID-19 Forecast Hub, evaluating some of these both short and longer term forecasts. And one of the things that we've seen pretty consistently is that, of course, measures of sort of point accuracy like mean absolute error, things like this, they degrade over time. It's obviously easier to predict what's going to happen in 1 or 2 weeks than it is in 10 or 12 weeks. Certain models do seem to be able to retain calibration. You know, they create really large prediction intervals far into the future, and are able to sort of retain nominal coverage rates for, say, 50, 80, 95% prediction intervals quite far into the future. And by that, I mean, there may be a few models that do fairly well at 10 and 12 weeks. But, you know, for example, I'm just going to pick on Sasha a tiny bit. The IHME predictions that we've seen for some preliminary results, the prediction intervals, you know, I think it's later 90 or 95% prediction intervals cover maybe 70% of the time, even at horizons like 15, 16 weeks out. So there, you know, the calibration is a little limited, and I think that's what we have to expect from really, really far predictions. What we've seen is that for death predictions of sort of incident mortality in 4 weeks out, a handful of models, and in particular the ensemble model, does tend to be fairly well calibrated and sort of retain that calibration really consistently, like 95% prediction intervals covering the truth close to 95% of the time. But then also, like I think it was Jurgen who said that that you sort of do well in different times of the outbreak, right? When it's harder to, it's sort of easier to predict when states are kind of trundling along at an even keel, and it's much harder to sort of predict that uptick, or predict when you're on the upswing, predict when it's going to turn around and go back down. There's just not, models haven't seemed to understand what data they can use to really help predict those change points.
Yes, and the reason is that in our view, there's just too much going on that is not in any of the models. I've mentioned all the politics, and Peter's mentioned it, and we can never really capture that in our models, I think. Obviously, the US elections are going to probably really have a big impact on how the US is going to change. Does that mean we also need to build in predictions of the US elections? I don't think we really want to do that. But I do want to pick up on another thing as well, and then I'll probably shut up for a little bit. When I make a forecast, I think it's what I expect to happen in the future. And I would like to keep that separate from scenarios, which are, in a sense, non-falsifiable statements, which things that might happen under certain circumstances. And I have the feeling we have to be a little bit more careful in communicating this distinction and communicating our forecast, because often they end up in the media saying they say, well, in 6 months' time, we're going to have X. And that really, I don't think was ever the intention of the research. And we really probably sometimes have to be a little bit more careful with the statements that we make about the future.
I completely agree with that, Jurgen. I don't know if Pete wants to jump in before I respond, actually, because I know, Pete, you haven't responded yet.
Oh, no, I was just raising a couple of questions whether there is a way to predict how long an epidemic will last. Just simply that. Because if you see my observation is if you see most of the models, you should expect an exponential time decay. While if you do the measurements, you don't see that exponential decay. Right, so it's more than a heavy-tailed distribution, and so that is a very interesting point for me. That probably something is wrong with the models, but I also don't know what. And another observation that I have: can we have a higher prediction by using two types of data? Like most of us, I I talk for myself, we use the predictions of the measured infected. And we only, we measure not everybody, so there is a large error on those numbers. However, the error that we have on those that have death, that are died, is much smaller. So by having a combination of the several compartments that you measure, but with a different accuracy, can't you then have an overall better accuracy? That was one of the things I was wondering about. So you measure the number of infected, the number of removed or the dead, and you measure, so in a model, it should be probably possible to have an overall, which is then better. There was a consideration, I would say.
I think when you look into the past, deaths are a really important indicator to try to establish how many infections happen in the past. And then there's fewer issues with accuracy, though there's still obviously a lot, especially when they're reported and so forth. But then when you get closer to the edge, then I think additional information is really important, including hospitalizations and confirmed cases, especially if you're cracking other things like the rate at which testing is happening. So always the other time series are important at the leading edge. And then I think deaths provide a reliable way to look back into the past. But there's a long time that can occur between infection and death, obviously. So.
Ryan, I wanted to give you a chance to chime in, and then I want to sort of pivot to thinking a little bit about sort of policy implications. There's been a handful of questions that have come in about that, and I just want to make sure we get a chance to cover that as well.
I think it's the perfect segue, Nick, because I'm actually about to maybe segue into that. So I wanted to echo Jurgen's point. I've been working with, our group's been working with not only the CDC, but folks in county departments of public health and state departments of public health. And I won't name the state, but I was, I meet regularly with some folks from the State Department of Public Health, and they currently consume about 12 forecasts, some of them from the Forecast Hub, some of them submitted independently. And they are not aware of the distinction that Jurgen, you just said we need to communicate better, that some models are meant as scenario projections and others are meant as forecasts. And it's actually a huge concern, because what they're currently doing is basically plotting all the forecasts and doing some kind of visual ensemble. And what they don't know is that some of the forecasts are predicated under different counterfactual assumptions that aren't made explicit. And so, it's been a struggle for us to try to basically explain to them, let's say how important a difference this is, and also to try to assist and build an ensemble when some components of the ensemble aren't even really compatible in terms of what they're trying to do. So there's a segue into your point.
Yeah, I will second Jurgen's or third or fourth Jurgen's point also, that I do think that this has, for me, really clarified, I think, for the field of infectious disease forecasting, which is sort of in many ways in its infancy. I think this pandemic has really accelerated the need to understand some of these conceptual distinctions between these models that we've sort of understood in an academic sense, but haven't communicated really clearly. So I think we're getting unfortunately, we're sort of learning as we go and getting a crash course in this here. I guess, so in terms of pivoting to policy decisions, people have asked, are forecasts being used for policy decisions? To what extent are, Ryan's talked a little bit about at least interacting with policymakers, but maybe some of you who have interacted directly with policymakers could just speak a little bit about the kinds of things that they're looking for, and you think that they're sort of interpreting. Do I need to pick on somebody? Maybe I'll start. So, I mean, we meet with I talk with folks at CDC several times a week. the forecast that we produce, and in particular, I would say this ensemble forecast that combines, depending on the location, somewhere between maybe 35 and 50 different models, is used in sort of a sort of grand dashboard that's run by HHS. People, so there are like decision makers in the government are looking at this. We've been told that vaccine companies who are trying to cite and sort of determine where they're going to run vaccine trials are really interested in particular, in the case forecasts for several weeks into the future, where they're going to try to determine which county in a particular state they're going to run a vaccine trial, and they're trying to pick between one of some number of counties, and maybe they could use our case forecast to help determine where those would go. Unfortunately, we're sort of not, these data are put out there. I mean, this is the benefit of an open science project, is all this data is put out, but you don't always know who the consumers are and exactly how they're using it. But I would say that's maybe one of the clear examples where we hope they're being used, and hope they're being used responsibly. I'm not sure how accurate our case forecasts are 4 to 6 weeks out, but that is certainly a use that we'd like to see them have.
You can jump in, but let me wait for a few seconds before I take the floor, because I want to make sure somebody else gets a chance. All right, so I want to just give a slightly different perspective that we've experienced. I mean, we've had a lot of similar interactions as Nick's group had, but one perspective that we've had is that a lot of, let's say, folks who are in smaller public health kind of offices, like a county, for example, Department of Public Health, that doesn't have a lot of sophistication, they look at forecasts as a crystal ball. So what they're expecting is for the forecast to give them something that they would never be able to see by eye, and they would never be able to do somehow themselves. And they're looking for something magical to come out of it. And I think this is a really dangerous notion, even when we're talking about short-term forecasts, that we've tried to dispel. And it's actually quite difficult to do so, because there's so much hype around forecasting, especially forecasting that uses, let's say, tools for machine learning or artificial intelligence, that people really believe that if a high-powered group is actually producing forecasts, then it's probably magical. And so one thing that we've done, and we've talked a lot with Nick about, is we've been producing various baseline forecasters. And the simplest baseline forecaster is the flat line, right? The flat line forecaster in terms of deaths. If there were, let's say 100 deaths yesterday, I'll predict there'll be 100 deaths tomorrow, so to speak. And we've been, this is actually, a version of this is actually up in the COVID Hub, there's a COVID Hub baseline. So we've been investigating the performance of various forecasters against various baselines. And I'll say that, these baseline models, they're not that easy to beat. I mean, they actually are beaten by, let's say, a handful of models, but not by huge margins, and not by every model. And so we shouldn't really be communicating, let's say, our forecasts as really being these magical creatures. I really think of them as improvements on the flat line, basically, to some order that's not like, a huge order of magnitude.
But that sounds like the random walk forecast, and it's quite well established that is really quite difficult to beat in many settings. So really, I'm hoping that we do better than that. I think we do, but it's not easy to always be better than that.
I'm wondering, we just have another few minutes. I'm wondering if any, Jurgen or Sasha or Pete, if any of you could just chime in about the sort of interaction with policymakers and sort of thinking about what the forecasts are used for, just in a minute or two.
Yeah, I don't have so much to say, because we kind of stayed away a bit from that and have just done it more as an academic exercise. And I've certainly heard feedback from some other groups that it has been very stressful to be in the public eye with your forecast, particularly as academics, you may not be prepared for that kind of exposure.
So I think IHME has had continued engagement efforts with policymakers, both in the US at different levels of the government and with other decision makers in other countries. But I haven't personally been a part of this. Indeed, as Jurgen just mentioned, it would be another intense, it would be intense for me to do so just in terms of time commitment. But I think I think clear communication is the way to go. And I think it takes sustained sort of ongoing effort. I don't think there's probably the sense that you just release something and it's out there and people will correctly interpret it. I think directly working with people on an ongoing basis is probably the effective way to do that.
Great. Well, we're basically at the hour. We haven't quite gotten to all of the good questions that have come in here. I may hang around and just try to pick off a couple more by text, but clearly, at least I believe there's another session that's coming right up here after us. So maybe we can sort of end the formal part of the Q&A. But Tao, maybe if you could leave the room open for a few minutes, just so we could chime in a couple of these, sort of provide links to folks and so on.
Yeah, definitely. So I'll leave the room open, and if you want to answer any questions from the audience, that would be great. Thank you all, and thanks to the audience as well.
Thank you, guys. That was fun.
Yeah, thank you all for joining, and again, Tao, thanks for organizing.
Thank you.
Ryan, are you still are you sticking around for a second?
Sure, I'm here.
Yeah, I think to answer one of your other questions that you brought in, I think it would be nice to see all the detailed data at the county and city level to be able to make more detailed county and city forecasts across the board. I think there's been some difficulty in obtaining all that data from the government, even when it has been collecting it. So there was an interesting op-ed in the New York Times. So I think that would definitely help get that level of that work out as well.
Were you referring to my comment about
The county
certain counties being hard to predict? Yeah. We've actually, so as I said at the beginning, we've been working on producing indicators all at the county level. So we have, I don't know how many, probably close to 20 at this point, different indicators that we produce that are all county level. We found it tremendously difficult to use them in a consistent way, consistent meaning spatially consistent. So like, I'll just give you an example. The survey we're running through Facebook asked people to report on whether they see somebody in their community with COVID symptoms. It turns out to be quite a useful proxy question, and it turns out to behave very, it has a very stable behavior with respect to incident cases. However, its behavior as a leading indicator is really spatially variable. In some counties, it consistently leads surges in case incidents by like a week or longer. And so as an indicator, it's extremely useful. In other counties, it doesn't lead at all. It appears to be basically, so we're not really sure why that is. We have a bunch of guesses as to why that is. And this is really true with the other indicators as well. We have indicators on mask use, mobility patterns, doctor's visits. We actually have indicators that are based on antigen tests being produced, which are not typically available through like COVID tracking or other websites that grab PCR tests mainly that are put up on state and county dashboards. But it's for us, it's like, we can't solve like hundreds of different modeling problems, one for each county, of course, right? And we also don't really know how to think about these consistently across counties. So we've been struggling, to be honest, with I say producing really smashingly successful models if I'm being honest.
I see. No, that makes sense. I was more talking about just hospitalization and deaths and timing of mandates, that kind of basic level information. It's very interesting the work that you're doing with looking at proxy information that you can collect this way.
Yeah, thank you.
Probably with all these counties, you should use a typical network approach and just you look the VS as one big network and they are all interacting with each other and influencing each other. And probably that might make sense.
Yeah, no, that's a great point, Pete. In fact, I have an he's a former student, actually. He's no longer my student. He's working on, I call it a network model, but it's just different terminology that comes from the neural network literature. So he's working on what's called a neural attention mechanism to try to figure out how to represent essentially counties in some latent state, such that there's, let's say, a latent representation for them that enables you to think about certain counties behaving in a similar way according to the latent features. And I have not seen his latest results, but he claims that by doing simple things like taking residuals on simple forecasters and training a neural attention mechanism to those residuals, which is like a network model, you can actually learn quite a bit, because there's quite a bit, those residuals basically there's quite a bit of signal left in the residuals, is what he's claiming.
Well, that's one of the things that Aleksandr is basically doing. You use all the transportation networks in the United States, and then you see basically the connections between the states. And if you have then also the infection data per state or county or village or whatever region you take, you might basically see how an epidemic propagates over time in the different places. Well,
I agree with this, although, from a strict forecasting perspective, if what we're interested in is pure accuracy, what we've seen is that simpler models are better. And, that the moment you start trying to take into account, connectivity between even just a couple locations, let alone many hundreds or thousands of locations, you end up in some sort of over-parameterized situation where it's really hard to learn consistent patterns between them. And honestly, the most accurate models, if you look at, rankings that have been put together by different sort of independent groups that are aggregating, the most accurate models are ones that are dead simple, essentially exponential smoothing on a time series. And that's just, it's really hard to beat that. And the models that try to incorporate mobility data or other pieces, I think are, just end up not being not being as accurate in a forecasting sense. Could they be useful to help with these sort of counterfactual things? Absolutely.
I'd like to echo that point. I think our approach is not nowhere near as simple as an exponentially weighted moving average, but it's relatively simple. That has the advantage it scales really easily. Once we got the 350 or so local areas for England, it took us just mainly it took us a day to get the forecasts up. And I guess I would argue that there's so many other things going on that putting a lot of accuracy in kind of things and a lot of effort in things that actually don't really matter that much for forecasting doesn't really help. It may be really useful afterwards when you try to understand what's going on, but for the actual forecasting process, we can check this, of course, afterwards. It's not clear that it's that helpful.
I think the drivers are very important because we don't live in a vacuum. We know that mandates have a direct effect, for example. We know that mask use has an effect, or at least we see it. So I think even when forecasting, counterfactuals or not, I think it's important to have a model that allows some that reacts to changes in the drivers. I know that opens up the complexity, and my modeling philosophy is that simpler is better when you can do it. But I think it's important to be able to consider these things. And so actually thinking about the discussion, Nick, curious when you're doing these tests, I think it's really good to check things, including calibration. But if you look at something where the underlying drivers changed, I think at least it's not obvious to me how that would go into a calibration test model. So for example, if the reference scenario is that mask use stays at 70%, and then one of the counterfactuals is if mask use goes up to 95%, we can save X many lives, and then actually mask use goes to 80%, then how you put that in an ensemble or check the calibration, I think it's a little bit challenging.
Yeah, right. I mean, for me, this would get back to Ryan's point about that. I don't see that as a forecast at that point. At the moment you're saying I'm conditioning on mask use being some percent going into the future, you're not integrating over all possible futures. You're saying this is the future that I'm forecasting for. And and there's a place for that model. Like that's a really important thing to be doing and saying, is looking at that model. But I don't see it as a strict forecast that's saying this is unconditional on any possible future. There's actually a participant who we're over time. I have about another 5 minutes and then I got to go put my kids to bed. But
sorry, I'm going to put myself to bed. But,
that's right. It's quite a bit later for you, isn't it? I gave Pablo I allowed Pablo to talk. So Pablo, if you're there and want to chime in with your
Yes, I'm here. Thanks. I'm here in Chile. So hello to everybody. Very interesting panel. I had a few questions. One question and a few comments on this one about forecasting accuracy. Actually, I'm an econometrician from economics, but so I was asking this question about the nature of non-stationarity of this series. You know, in economics, we usually deal with series that have unit roots, but this is not the case with cumulative cases of incident cases, deaths, whatever, infections. So you have these S-shaped curves, logistic type curves, and different, and again, different regimes that you experience different outbreaks. So we have some very unusual, at least for me, sources of non-stationarity that is puzzling from the point of view of the properties of statistical tools, like least squares. What are they convergent to what? Central limit theorem, standard deviations in forecasting intervals. So how do you deal with that? That's my major question, because I'm not really used to work with this data. In economics, we just differentiate the data until it looks or it indicates that it is stationary, and then we're okay because central limit theorem, standard deviations works well. But otherwise, we are not sure about that. So that's the question. And just a comment regarding forecast accuracy. In terms of accuracy, sometimes simpler models work best because it's the way we are evaluating accuracy. We tend to measure accuracy as mean square forecast errors. It turns out that kind of loss measure put a lot of weight on the size of the forecast. And by the size of the forecast, I mean the expected value of the forecast, of the square forecast itself. So when you're talking about the zero forecast of a random walk, it has zero size. So that's why it's so accurate, difficult to beat in terms of mean square forecast errors. But in terms of other loss measures, it is easy to beat. So that's just a comment. So a question and a comment. So I don't know if you can help me out with this, because I'm trying to write a paper on this, but I'm not really used with these techniques that you probably are really used to.
Yeah, maybe I should say something, because I threw the word non-stationarity around quite freely. I guess we've been thinking a bit in the kind of explosive states, more like an I2 type problem rather than I1, but where we allow for it normally in economics be restricted to linear trends, but we allow higher order trends. And then effectively afterwards, when things settle down, it may be shifting more to I1 type model. So it's not something that is constant, but that helps, certainly I think helped us to think about it.
Great, thanks Jurgen, and thanks Pablo for the question. We're long over time. Thank you. We have the few and the really dedicated 11 attendees who have hung in there. Thank you for your continued interest, and thanks to the panelists, especially the ones in Europe, who are the last one standing, despite it being past midnight there now. Or so in any case, thanks again to everybody for joining, and we hope you enjoy the rest of the conference.
Okay, bye-bye. Sleep well.
Bye-bye.
Bye. Thank you, guys.